Over to you, Dr. Divya Balakrishnan. Madam is Senior Consultant in LF. Over you to you, ma'am, for surgical options.
Thank you, Anubhav and KSOS for giving me this opportunity. And please. So we don't want any babies to go to this stage actually. So whatever the talk which was given before, it should happen, and this should not happen. But despite all those efforts, sometimes babies do end up in this stage. So when it happens, so when do we intervene surgically? So the indications is like when there is a stage 4A, and if it is like 1 or 2 clock hours, still maybe you can try little laser, little posterior, and then see sometimes it regresses. But when it is more than 2-3 clock hours, then you have to keep really a close watch, and maybe we will have to intervene early. And then stage 5, which we don't want to see at all. And in some babies, unfortunately, when they present this late, then still we can do surgery. And at least in those cases, actually, you don't expect that babies to see like a normal one. But at least some mobile vision, or at least if they can recognize whether it is daylight or night, or read things or see things very close. And when there is a vitreous hemorrhage, this can happen even during the normal, sometimes it could be, it may not be even ROP also, when there is a coexisting systemic factors and or associated with ROP. Sometimes post laser, even late also, you come across some combined retinal detachment, because if your breaks are really very intense, so you have to be very careful. Sometimes you see these kind of even in the late presentations also. So before intervening, especially when it goes to stage 5, you do an ultrasound basically to rule out any other underlying pathologies. Second thing is to see what is the shape of the funnel, whether it is posteriorly closed or open, which helps to plan the prognosis and also your surgical interventions. And see, surgery in ROP, because you know all these babies are preterm and they have multiple systemic issues sometimes. So very important to actually do a proper systemic evaluation, including the systemic parameters like hemoglobin, the platelet count, if there are any other associated congenital diseases. And you need to have a dialogue with the anesthetist and the neonatologist. You may have to shift the baby immediately after surgery to an NICU setup. So, and you should inform the parents, like in case of any anticipated untoward event, then the baby need to be under follow-up, and all these things with counseling and a coordination between anesthetists, neonatologists and parents is very important before taking up any of these babies for surgery. And what do you do or in a surgery, or how do you plan it actually? So the aim of the surgery is, especially in stage 4 and 4B, reattach the retina, and to some extent it helps in the regression of the vascular activity. So what are the options? So you have an options of a scleral buckle and a vitrectomy. Scleral buckle, especially you can even try segmental buckle, that help to reduce the post-op myopia in some cases, and then belt buckle in some cases. Vitrectomy especially, it can be either a lens sparing or sometimes you have to manage it with a lensectomy. So how do you decide between these options? So it depends upon the zone of the disease, the stage of the disease, what is the nature of the vitreoretinal traction, the extent and the type of the retinal detachment, and whether the disease is still active or not. So if the disease is still active, especially when there is an active neovascularization of iris, then you may have to do a pre-op anti-VEGF 1 or 2 days before, and then take up the child for a vitrectomy in those cases. So how do you decide between vitrectomy and the buccal surgery? So if it is a posterior disease, zone 1, then you will have to go for a vitrectomy. If it is zone 2 or zone 3, and a stage 4A where the traction is in the periphery, where it can be supported by the buckle and there is not much of a posterior traction, then you tend to do only a scleral buckle or a belt buckle procedure. Where there is a stage 4B and where the macula is off, then you will have to combine with a vitrectomy and a belt buckle. Stage 5, obviously you will have to go for a vitrectomy, and in most of these cases you will have to do a lensectomy also. So the basic principle you have to keep in mind is that when the traction is in the periphery and it is anterior, then you can go for a buccal surgery. If there is a posterior membrane and the posterior zone disease, then you will have to go for a vitrectomy. So what do you do in a vitrectomy, or how this traction happens? The tractional forces are, one is anterior to posterior, then circumferential and tangential tractions. So circumferential, you can see you might see that along the arcades, the superior and inferior arcade are getting connected temporally. That means like there is a ridge to ridge traction. That is what you call a circumferential traction. Anteroposterior, you see that posterior from the disc, the retina get lifted up anteriorly towards the lens. So in some babies with a delayed presentation, you might see with just beneath the lens, you can see the retina and the fibrous stalk coming up. So that is the anteroposterior traction. And then in the tangential, the entire thing would be pulled towards the disc. So what do you do in a scleral buckle? You actually change the vector force so that the periphery doesn't get dragged to the anterior. So that is what you do by doing a scleral buckle. Sometimes you can do a segmental buckle if the traction is limited to 1 or 2 clock hours. And vitrectomy, actually you are releasing those vitreoretinal traction, the traction force is removed, and along with that you remove the angiogenic factors. But it is a little difficult in these eyes because the anatomy is little different. There is no well developed pars plana in these patients, so you are actually entering through the pars plicator region. So you have to keep these things in mind when you operate, and you have to measure your sclerotomy distance accordingly depending upon the age of the baby. And so the main aim of the surgery is to attach the retina, because it has shown that eyes with a detached retina had very poor anatomical outcome and functional outcome, and anatomical reattachment is very important for preventing the future complications and for a better visual outcome. So this is one video which shows, you can see that there is a superior and inferior arcade which is lifted up, temporal there is a traction, so you release those traction, and here you can see between the disc and the peripheral ridge there is a traction, so you release that one. And the second word would be anterior to the ridge and between the ora serrata. So the aim of surgery is not to settle the retina intra-op, but to release the traction with the minimal dissection and leave it. So it will take time for this retinal folds to come back to normal, to reattach. In stage 5, it is a very difficult thing, and you don't want any babies to go to this stage. So basically the aim of surgery is to release these traction membranes, remove these membranes. So you will have to do a lensectomy in these cases, and you just let the retina settle by itself. It will take few weeks and months for it to go back. You don't anticipate these patients to get very good vision, but at least a mobile vision. So that is what the aim of surgery in this stage 5, and the functional outcomes are very less in these cases. So as I mentioned, the aim is to prevent further progression and to achieve maximum what is possible for this. And it doesn't end with the surgery, but you need to follow up these babies for refractive error, refractive corrections, intraocular pressure monitoring, and proper visual rehabilitation. So your job is done only when you do all these things. And thank you.
Thank you, madam. Yes, what madam told in the last, just doing surgery and settling the retina is not enough. In these babies especially, you have to do post-op management in terms of visual rehabilitation, which is very important for long-term vision survival of these babies.